teaching and training of psychiatry and the behavioral sciences to the undergraduate students of MMBS, MSc, postgraduate trainees, and paramedical staff. And he teached more than 30,000 physicians and doctors, produced more than 55 psychiatrists in the country, published 9 books, and he is examiner at all leading universities of the country, and above all has been teaching to all mental health professionals for more than 33 years. So let's start with Professor Muhammad.
Inviting me to present in this wonderful conference. I want to be there personally, but unfortunately because of some personal reasons I was not able to. But I'm very grateful to Dr. Abdul Javed, the President, WPA, and others, and all the staff. I opportunity. Thank you very much.
Thank you very much, Professor Muhammad, to have you with us. It was a pleasure. Do you have any questions with Professor Muhammad? Any questions? Yeah, Doctor, maybe I would like to add, I noticed that usually when we follow the guideline, we have, I mean, UAE is a multinational country, so we get used to have an inpatient, different nationalities. For some doctors, when they come from Canada or Europe, some of them, they want to follow the guideline and they are expecting a same response to medication. Then they're surprised that, for example, some patients there with 5 milligram, they have good response, but for us, even till we reach 15 milligram or 20, then we have a response with good result. It's always, we will keep a need for a regular researches, our own observation for our patients with their genetics and the different variation.
Exactly. I agree. This is another situation where the people coming from various backgrounds, various cultures, this is proof of everything.
A fixed belief.
Gives me another viewpoint that how then the rehabilitation for the should be described. For treating schizophrenia, the same medication is available in the US and the same medication is available in UAE, but the response to the dosage is different.
Yes.
And the cultural aspects, and the religious aspects, and the social aspects. So this means that the rehabilitation process, which is practiced actually in US and Canada, will be much more different than what we need in UAE
Yeah.
or in Pakistan or in India. That will be different. This means that every individual, the treatment strategies for the modification of the rehabilitation processes will be different. And this is, again, a complex situation for
Yeah.
psychiatrists, for mental health professionals. I cannot provide the same kind of intense training rehabilitation to the person who is in Pakistan as compared to the same person who is in the US.
Yeah.
Difference of resource, difference of finances, difference of the social and cultural aspect,
Mentality.
and religion as well. All of these things. So this is what confuses me. We know that ICP learning can be practiced across the globe. But
Yeah.
we know that these rehabilitation processes won't work the same way as they will work in one environment as compared to maybe the other city as well. So I agree with you, yes, this is complicated, this is complex, and this is what my question is always there, what to do more.
Yeah, even when I moved to work in a rural area, I noticed that some patients, when we start mindfulness or when I start to motivate them to do a psychotherapy session, even after 4 or 5 minutes, they say, they open their eye and they stop breathing and they say, okay, okay, medication, let's move. Fa- yeah, maybe
agree.
I,
This is
yes,
so they feel that these strategies probably won't have it done. Actually, if you will not try them, how
yes,
do you know that this will
yes,
won't be effective?
yeah.
Maybe you don't need a pill, you just need these things.
Yes. فrespecting and value expert experience, opinion will make a big difference. I notice some of my colleagues, when they are a junior, they start to think, oh, this consultant is not following a guideline, but maybe after years they will become same to the consultant. They will discover a lot of things. Some of them, they start to follow the guideline, then they discover the variation, and they start to design the right rehab, the right medication, which design this particular case.
So the genetics, unfortunately, is making things more again, more either simplified or difficult. I
Yeah.
don't know. So if you want to know which medicine can be suitable to me, I can go for a genetic testing and they will give me the list of the medication which will be suitable for me and which will give me
Huh.
a side effect. That can make it more complex and more complicated. Okay, fine, so I have to spend money on my genetic study, which even in US and Canada costs about $1,000 for microarray for genetics. $1,000 is a huge amount of money. And this will cost probably hundreds of thousands of rupees in Pakistan. I cannot ask my people to go for these testings there. Okay, fine. And then if I know the medicine that this is the right medicine for this person, again, am I sure that the outcome will be the same? Again, environment, social culture, so many other aspects. If I have to refer somebody here for the rehabilitation, not just psychology, the wait time is variable. In Pakistan, sometimes people can see a psychologist maybe in a week's time. In US and Canada, wait time is almost 6 months.
Huh.
Despite having the services available, there are limitations there as well.
Yeah.
Despite services available in Pakistan, there are limitations there as well because people don't accept it that this needs to be done.
Yeah. Yeah. Thank you, Professor. Thank you very much. Do you have any
You're
questions?
welcome and thank you very much. It was, again, pleasure was mine to talk about it. I hope some people will be able to learn something out of it.
Yeah, sure. Thank you.
Thank you. Take care.
So we will move to Professor Danuta and suicide session 8. Suicide can be prevented. Few minutes and we will start, inshallah. Professor Danuta Wasserman is a professor of psychiatry and suicidology, head and founder of National Center for Suicide Research and Prevention of Mental Health at Karolinska Institute in Sweden. So she's a university professor in psychiatry and suicidology since 1993 with a great experience, big experience. Will share it with us, inshallah, today. And she is appointed as the director of the WHO Collaborating Center for Research, Methods Development and Training in Suicide Prevention since 1997 until 2024, and assists in the development of suicide preventive research and suicide preventive programs on 5 continents. She is the former president of the European Psychiatric Association and the International Academy of Suicide Research. In October 2020, was elected as the president-elect of the World Psychiatric Association, incoming as a president in 2023 till 2026. Professor Wasserman is the honorary fellow of the Royal College of Psychiatrists in the UK, honorary member of the Hungarian, Polish, and Romanian Psychiatric Associations, and president of Estonian Swedish Mental Health Institute.
solution identification. My name is Danuta Wasserman, and I am professor in psychiatry at Karolinska Institute, which awards the Nobel Prize in Physiology or Medicine each year in Stockholm, Sweden. I am also director of the National Center for Suicide Research and Prevention of Mental Health Problems, and the director of the WHO Collaborating Center. My lecture comprises three parts. The first part will be about the epidemiology of suicidal behaviors and the theoretical model for suicidal behaviors. The second part will be about evidence-based suicide preventive methods from the healthcare perspective, and the third part, suicide preventive methods from the public mental health perspective. And by the end, I will also say something about suicide prevention during COVID-19 pandemic. At our institution, we work with epidemiological surveillance of trends around the world, trends in suicide, with research, education, and development of preventive methods. We have many funds from European Union on monitoring suicidal behavior, but also working with the preventive programs in prevention of depression, whose persons with somatic diseases. We have also a basic research, and I will give you some results from this research later on. The World Health Organization has a data bank on mortality, which has grown from 33 member states in 1950s to more than 130 member states today. And there is an approximation that 8,000 people die by suicide in the world each year. Of course, this number are strongly underestimated due to different monitoring and registration methods, as well as to cultural biases. We know that in many countries suicide is still taboo, and in a few countries forbidden. Globally, suicide is the second leading cause of death for young people, usually after death in traffic accidents or tumors. It is approximately calculated that 20 people attempt suicide in relation to each completed suicide. And this is true for young people, but not for elderly. In elderly, the ratio is 1:1, which means that we must very eagerly investigate and treat and follow up elderly people. The annual suicide rate in the world is approximately 10 persons per 100,000 world population, higher for males, for almost 14, and lower for females. And we can see this relation in all 6 regions of WHO. If we calculate that it is 800,000 to 1 million suicides per year in the world, we can see that in every 40 seconds there is one death due to suicide, which is a horrible number. And suicide causes 57% of all violent deaths when we calculate deaths due to suicide, war, and homicide together. When occurs suicide? Suicide occurs where it is imbalance between protective factors and risk factors. In the state of good mental health, there is equilibrium between risk and protective factors. And WHO is using this model for preventive activities, which we call social ecological model, because suicide must be prevented on several levels level of individual, family, community, and society. To the risk factors on the society level, we can count economic and social inequalities, unemployment, poor accessibility to the healthcare services. On the individual level, we speak about major depressive disorder, about psychotic disorders, alcohol and drug misuse or abuse, etc. And we have also on the relationships level that suicidal people are very lonely, so loneliness is a big problem, even lonely in their own families because they are poor communicators and cannot seek help as well as other people. Protective factors is, of course, good access to the healthcare, good access to the community services, family support for treatment, to give good support so patients comply to treatment which is prescribed. The sense of self-worth on the individual level and the sense of that one is connecting to friends, neighbors, or peers in school or in the working places. We will shortly look at the theoretical model behind the suicidal behaviors. This model is called stress vulnerability model and takes into consideration gene and environment interactions, and also the acquired and inherited vulnerability, which sometimes is called diathesis. According to this model, if we have stressful life events which are hitting vulnerable individuals with diathesis prone to suicidal behavior, those people start to get imbalance between protective and risk factors. And stresses can be of different kind. It can be unemployment, it can be family problems, discord in the family, etc. We know also that the role of environmental factors and genetic factors is 50-50. And there are many genetic studies showing that there are different reactions to stress in males and females. My group, which studies suicidal behaviors in relation to the genetic makeup of the individual, in interrelation with stress and personality, showed that males are much more prone to act with suicidal behaviors to already very low levels of stress in comparison with females. So maybe it can be one of the explanations why the rates for males in the world, rates of suicide, are much higher than female rates. So my group also defined 40 suicide behavior specific genes. This work is in press in European Journal of Neuropsychopharmacology. And this is in line with the previous epidemiological psychiatric studies showing that suicidality is inherited independently from psychiatric disorders, which means that patients who have psychiatric disorders, not all of them are suicidal, and we know it from the practice. Only some of them which have this genetic makeup, and there will be certainly many more than 40 of those suicides behavior-specific genes, and in interrelation with stress or other environmental factors, they react with suicidal behaviors. Those genes we identified now are major neurodevelopmental genes, and with regard to the gene-environment interactions and epigenetic effects during childhood. Those 40 suicidal behavior genes which are identified now, we can compare with 3,900 genes which are already identified today for psychiatric disorders. Coming back to stress vulnerability model, it contains also the development of the suicidal process from suicidal ideation, communication, suicide attempts, and completed suicide. It is important to study this process because the interplay between suicidal communication from the suicidal person and the family and the staff, care workers, is very important. What I mean by that is that the answer from the key persons, I mean answer from the family, answer from the care staff, to the suicidal communication can save the life of the suicidal person, or it can be detrimental. We not so seldom react to the suicidal communication with silence or ambivalence due to the lack of knowledge, because we don't know how to answer when somebody is communicating that I think that I am going to kill myself. Those communications can be performed in different forms: verbal, non-verbal, direct and non-direct. And it can be very strange interplay between the suicidal person who seeks help and the family member or staff from psychiatric hospital who is maybe silent or ambivalent. I speak here about the mechanisms of transference and countertransference in the relation between doctor and suicidal patient. And we all need to be aware that suicidal communication evokes, even in professionals, very strong feelings of emotional feelings, because we choose our profession to save lives. And here we are confronted with an individual who doesn't want to live any longer. Now I will speak about prevention and evidence-based preventive methods. From the health care perspective, it is very well known that antidepressant drugs, lithium treatment, neuroleptics, psychotherapy and psychosocial measures have evidence for significantly decreasing suicide and other suicidal behaviors. Concerning antidepressants, we know that we need to use antidepressants with tranquilizing effect, because many suicidal patients have quite big anxiety, and the anxiety is the motor for this development of the suicidal process I spoke about. When we treat schizophrenia, especially chronic schizophrenia, there are studies showing that suicide on different continents, and we had a treatment as usual group, which was a control group, and treatment as usual with brief intervention contact, which was an intervention group. And in this group, which was intervention group with brief intervention and contact, the doctor or psychologist had a 1-hour individual information session after suicide attempt about reasons for suicide and possibilities for help and treatment before suicide attempter was discharged from the hospital. Then we had an independent person, which was a student or volunteer, which through phone calls or visits had 9 follow-up contacts with the suicide attempter, 1, 2, 4, 7, 11 weeks, and 4, 6, 12, 18 months, altogether 9 contacts during an 18 months follow-up. The results were amazing. Mortality by suicide decreased significantly from 18 in the control group, which was treatment as usual, to 2 in the intervention group, where we had treatment as usual and brief information and contact. Which means that we have low-cost brief intervention, which can be used both in high, middle, and low-income countries. I am planning now, together with World Health Organization, with World Psychiatric Association, and with Karolinska Institute, which contracted some sponsors for that study on hopefully all continents, to describe partly responses concerning mental health indicators and suicide as an indicator of different nations to COVID-19 pandemic, but also to perform this treatment as usual in combination with brief intervention and contact follow-up, and to see if we can, with digital methods, new way of following up suicide attempters, obtain these similar results as before. And we will have countries both from Latin America, United States is interested, they performed already a pilot study before, Europe, Africa, and Asia. From the public health perspective, there are also several preventive methods. Restriction to access of lethal means of suicide is a very important method of preventing suicide. Control of pesticides, regulation of firearms, barriers at jumping sites and hotspots, reducing hanging possibilities and ligature points in hospitals and prisons, and reducing availability of medications, selling them over the counter in small packages or blisters, show significant decreases in suicidal behaviors. In one study which I performed many years ago in the former Soviet Union, during perestroika means restructuring during the Gorbachev's time, if you remember this time, we could see that suicide due to the sale of alcohol, there were alcohol restrictions on producing and selling alcohol, but they were also actively promoted changes in the attitudes towards using alcohol. We could see that suicide for men decreased by 32%, with comparison in Europe, 3%. Also, deaths from homicide and from violent causes due to external injuries decreased. And it was very interesting that suicides decreased in all 15 former Soviet republics, both with low and high suicide rates, both for males and females, but most significantly for men. So it was one natural experiment which shows that it is possible to decrease suicide among men. Media reporting is another measurement which is very important in suicide prevention. It is very important not glamorize, not romanticize suicidal behavior, because it has impact on vulnerable individuals in psychiatric hospitals, prisons, indigenous reserves, that there can be a cluster of suicides due to inappropriate reporting by media. And they are guidelines from World Health Organization. There are also guidelines from American Foundation for Suicide Prevention. School prevention are also important because children are entire day in the school. And in schools, we can follow both somatic development and psychological development, and also use some time for preventive intervention. Those which are evidence-based, it is described by David Brent in Journal of Child Psychology and Psychiatry 2018, is the good behavior game from United States and Youth Aware of Mental Health, YAM, from Karolinska Institute and Columbia University in New York. And in those interventions, we are using cognitive, emotional, and experiential learning methods. They are not long. Youth Aware of Mental Health is 5 hours intervention during several weeks in order to run it a little bit like a psychotherapeutic process. From this study, where the YAM, Youth Aware of Mental Health intervention, was studied, study is called SAILI, Saving and Empowering Young Lives in Europe. We described in more than 50 papers different risk protective factors, the effects of intervention, and I would like to share with you the important protective factors for mental health and suicidal behavior where we could see a very strong association. Poor sleep, lack of physical activity were risk factors associated with suicidal behavior. Reading books, unfortunately we are not reading so many books, especially young people today, but reading books was significantly associated with protective behaviors against suicide. The same is concerning abstaining from alcohol use. So there was shortly overview of evidence-based suicide preventive strategies. I would like to repeat what I said before, that public health, mental health approaches, they go hand in hand with healthcare approaches. So don't use only one approach, try to use both of them. And the description of all those approaches, one is in a book which was published in 2016, Suicide and Unnecessary Death, which is very easily written and can be read by busy clinicians, by students, by public health workers. And Oxford Textbook of Suicidology and Suicide Prevention is a big book. It is a book like that. And this is a book for researchers. So it is a very good coverage of what research says up to today and what more can be done. I would like to thank you very, very much for listening to me.
Thank you very much. I think it was a very interesting talk. And unfortunately, there are only 37 minutes left to finish this session, and there are 2 speakers. But what I'll try to do is one of speaker is me. My name is Shahid Qureshi. I'm a psychiatrist working in UK in low secure and rehabilitation unit. My talk is about pathways of care for first episode of psychosis in mental health services in UK. I think that is wrong. I'm not a Deputy Secretary General anymore. I was, and I'm ex-Deputy Secretary General. After me, I have another speaker, Dr. Walid Abdul Khalil Nasser. And what I'll try to do is I'll try to be very quick to finish my presentation. Can I have my slides on, please? This is a personal experience which I'm going to share. I'm not going to dwell on psychosis, what psychosis is, and I will mention briefly about how NHS works, nice recommendations, and of course, share my personal experience with you. And then I'll summarize the findings. I don't think that there will be a time for questions, and if you have any questions, you can always email it to me. I'll share my email with you in the end. I mean, psychosis is a broader term. Basically, it means that person experience different what you call difficulties. I'm not going to go on diagnosis. There's a list of diagnoses, and I hope that there are psychiatrists sitting here in this room who will understand what psychosis is. However, behavior has been described challenging where it is of a degree and severity and frequency that affects person's life. And this definition has been agreed both by Royal College of Psychiatrists and British Society of Psychologists. Why it is important to treat first episode of psychosis? The reason it is a transition time from childhood or adolescent to adulthood. Although I must confess here that these days it is quite obvious that every person who experienced first episode of psychosis is not necessarily a young adult. A lot of people in older age or middle age do experience first episode of psychosis. But it is important particularly of adolescents because it's a change time. They go to university, they become independent, some of them get married, some of them get employment, find new jobs, move away from home, and etc. that you can see on this slip. They do not present with what we normally call first-rec symptoms or traditional symptoms of psychosis that we are familiar with, hallucinations and delusion. Usually present with depression, feeling anxious, they feel irritable, and there's a disturbed pattern of sleep that they would report and often will be confused and muddled up. Noticing things people seem strange and unreal, and being preoccupied with particular ideas or thoughts. Unusual experiences such as seeing and hearing things, although when I have said they don't experience the typical first-rank psychotic symptoms, they experience hearing voices, but these can be as somebody has called their name or seen something which they will not be able to describe. Preferring to spend time alone, become aloof, and mainly drift away from family and friends, is struggling to cope at home and school. Clinical features, I'm not going to cover this either. The reason it is important that when they experience first episode of psychosis, only 88% of them recover after first episode of psychosis. And then each further episode, their progression decreases, and therefore it is very important that these people are treated in time and earlier. OASIS, I took this from OASIS Outreach and Assessment Services in South London. Other reasons is that for first episode services or early intervention services is that there was a positive experience by patients and their families as found by McKenzie in 2006. Service users expressed dissatisfaction with the general services of community mental health teams as found by Ettridge in 2004, and adhering to practice guidelines of first episode psychosis was appreciated as seen by O'Toole in 2004. NHS, those of you who have worked in England are familiar. It has two-tier systems, a primary care and secondary care. And primary care basically is provided by the general practitioners, nurse practitioners, and the self-help information and pharmacy. Secondary care is a more specialized services where you see psychiatrists and community mental health team, and it will be a list of other professionals working with them, like psychologists, and nurses, and their different teams, single point of access, crisis resolution home treatment team, CMHTs, early intervention services, assertive outreach team, and inpatient mental health services. NICE suggests that we shall be treating patients for the first episode of psychosis because first present psychosis, irrespective of patient's age and duration of untreated psychosis, because previously they were only offering this treatment to young people, but now they have expanded it to across the age. People presenting early intervention services should be assessed without delay. If the service cannot be provided urgent intervention for people in crisis, refer the person to the crisis resolution home treatment team, where my personal experience come from. A referral may be in the form of primary care or secondary care, and early intervention in psychosis services should aim to provide a full range of pharmacological, psychological, and educational and social management. Consider extending the availability of early intervention psychosis services beyond 3 years, because these services were only limited to provide for first 3 years, then people were just discharged. Now they have extended it beyond 3 years. Do not start antipsychotic medication unless seen by a specialist. Psychiatric problems should consider all the risk harm condition like suicide, drug, alcohol use, and also it involves full medical interventions, and physical health and well-being is also looked at it. Psychological and psychosocial interventions are also provided. Development of social, cognitive, and motor development and skills include coexisting neurodevelopmental conditions, because these days more and more we are coming across people who are present first time that they had undiagnosed neurodevelopmental conditions. Important thing is rule out PTSD, monitor their coexisting conditions, develop and care plan should be developed in collaboration with the patients, and arrange an alternative learning opportunities where mainstream education is difficult to achieve. Main thing NICE suggested that we shall be able to offer medication choices, CBT, and family interventions. My personal experience, as I mentioned, this was when I was working as a consultant and crisis resolution home treatment team. Crisis resolution home treatment team basically refers to a system for a rapid response and assessment of a mental health crisis in community, with possibility of offering comprehensive acute psychiatric care at home, so the crisis is resolved and usually without hospital admission. More often than not, majority of these patients were seen by us first before they were seen by early intervention services. Acute care is delivered by a specialist team so as to provide alternative to hospital admissions for individuals who are experiencing acute difficulties. Anybody could refer to us, GP, self-help, A&E, drug teams, voluntary organizations. Early intervention services can also refer patients back to us, assertive outreach team, CMHT, and inpatients. After a referral, we were doing exactly the same what was expected by early intervention services by the NICE guidelines. We provided a full assessment, we provided a home treatment team, avoiding inpatient, but where inpatient were necessary, we would admit them, and when they were managed and treated, would re-refer them back to the CMHTs and early intervention services, or sometime back to their GPs, and our voluntary organizations, our drug teams. This service was primarily for people who are adults, 16 and above, suffering from severe mental illness and presenting with acute psychiatric crisis of the nature that requires inpatient hospital admission. This was not for mixed anxiety disorders, primary diagnosis of alcohol or substance misuse, brain damage or other organic disorders, learning difficulties, and exclusive diagnosis of personality disorder, and recent history of self-harm, but not suffering from a psychiatric illness or a severe depressive illness. These people, basically what I'm referring to is those who suffer from emotional and unstable personality disorder. A crisis is not related to social problems either. We were able to offer them full assessment, we were able to offer them medical reviews, we were able to offer them medication reviews, we were able to offer them regular visits by nurses, psychologists, social workers, and arranging psychiatric outpatient clinics, and psychological support, and provided them education and monitored their compliance with the treatment. And we also worked with the families and carers. We offered them occupational therapy assessments, provided them social support, and included them in social arena, and provided them community-based rehabilitation, and offered them regular clinical reviews. And CPS, it's a term that is used by NHS, is a CPS, a care program approach, and offered risk assessments. Basically, in summary, we were able to offer them a full comprehensive psychiatric assessment. It was a multidisciplinary team approach, looking at the psychiatric, medical, and psychosocial interventions, medicine management, risk assessment, and education. So, employment, social inclusion, and rehabilitation was part of it. I'm sorry, I had to rush because I am aware that there is another speaker as well, and I did not want him to be deprived of his presentation because of the time and one extra presentation that we had without at least in my knowledge. Okay, so without making any delays, any quick question that you have? I said probably I wouldn't be able to answer. If not, you had my email address. I would like to invite Dr. Walid Abdul Galil Nasir. He's a consultant old age psychiatrist at Al Amal Psychiatric Hospital, Abu Dhabi, UAE. And he's a psychiatrist for more than 18 years experience. He's currently working as a consultant old age psychiatrist at Al Amal Psychiatric Hospital, Emirates. He has a MRC Psych from UK in 2022. He has a master's degree in psychiatry and neurology from Alexandria University in Egypt that he obtained in 2011. And he's a clinical master's degree of a clinical master's program in which he had completed training both in psychiatry and neurology. And he completed his undergrad in 2002. It's over to Dr. Walid Abdul Galil Nasir.
First of all, thank you, Dr. Shahid, for your kind presentation and also the fruitful presentation. My topic today will be on one of the growing area in psychiatry, that is palliative care. My understanding is that most or maybe more than 55% of us has at certain time of their life provided palliative care to one of their close family members or a friend, but without knowing that it is a palliative care. So why there is a need for the palliative care in psychiatry? Initially, I don't have anything to disclose, and this is our topics. I'm sorry I will be rush and hurry so as to be compete with the time that has been allocated for us. So palliative care in psychiatry, it is provided at a sort of service that is will provided to a terminal people. So what is terminal ill? Those are patients who are having such kind of medical health problem, either a physical health problem or a mental health problem that is not amenable to cure. It is uncurable and irreversible, and they are presented with either physical complaints, psychiatric complaints, or social and spiritual problems. So there is really unmet need for palliative care. Actually, around 56 million patients all over the world are in need for palliative care. However, around 14% of those patients, they get the service and they approach it. Also, there's one study that has been conducted in Australia. More than 65% of the carers and the patients are not aware that there is a palliative care service. One of the challenges also that hurry the need for the palliative care service, it is the aging of the people. Now we reach to up around 87 or 88 average age for ladies and around 78 for men. This means that the population are aging, and once the population are aging, there is a high probability to have a more prevalence of dementia. And as we know, dementia patients, they will turn into severe and late onset, late or final stage dementia within 1 to 3 years. So this is the diagnosis of palliative psychiatry, and I need just to highlight that what is the difference between curative psychiatry and the palliative psychiatry. In curative psychiatry, our goal is that to cure patients. This means that we are providing treatment to get a proper remission of the symptoms and the patient to return back to their function, so he will be functionally well. For example, we have a famous common example, it is schizophrenia. And we know that around third of patients, they'll get after treatment, they will improve, they will back to their work, with their life. However, second to third, they will be between relapse and admission and improvement. And there is a third of patients that are resistant to treatment, and unfortunately, they will be kept in some of the inpatient facilities. So those patients who will not receive medication and they will not get a response, and it will be like in a progressive manner, and they will not be curable, and the symptoms is challenging for them, challenging for the community. They are really in need for some sort of palliative care. Dementia, it is one of the diseases that is unfortunately, it is one-way journey. Once a patient will start getting the illness, it will progress with time until the end on that they will pass away. So in palliative care, it is a holistic approach where we will work to provide and treat both the physical complaints, for example, pain, and also to treat the psychological problems, and along with the social care or support and the spiritual needs. So this diagram, it really covered the spectrum of palliative care. Usually palliative care, it starts when the disease starts. For example, once the patient start to get dementia, at that time we'll start with what we call advanced care plan. So we'll start addressing the problem, discussing the diagnosis, the prognostic factor and the prognosis of the disease, and what we should provide. Also, we should maximize the comfort of the patient, at least as we can do, maximizing the functionality time and the living time that he can do. And second, it is the end of life care, where the patient will start getting more severe symptoms. For example, it might be from weeks to months, and the patient at that time will be more disabled. He will be in more need for support, either from the family, from the physicians. At that time, he might need some what we call hospice care. In the terminally or the last days care, it will be just maybe a few days, hours, in which the patient is severely debilitated and is in the last hours or days for his life, where he needs just to manage the symptom and to keep him as much as comfort. After that, also the palliative care continues. So we look after the families, providing them the bereavement therapy and management for the lost person. This is with the WHO key elements of palliative care. It starts from addressing the problem with the patient and the families, how to cope with it, passing to discussing the possible options available, the treatments that he likes and he dislikes, and the things that can be provided in the future, where the things should be avoided. Also, sharing with the family members, start to pay his attention that he has to take an action, for example, how to manage his social, his financial issues, if there is. Here it is the continuum of the palliative care. As you can see, during healthy life, we usually work as a health practitioner to prevent diseases, for example, through vaccination or primary prevention. And in case any of us get ill, for example, got tonsillitis or whatever, we'll take an antibiotic or can get tonsillectomy. However, if the symptoms are and the disease is incurable and irreversible, at that time we start considering a palliative care, where we will start working on managing the symptoms, as mentioned, and next to that, when the patient will get for expected less than 6 months of life expectancy, we consider hospice. And after this, we'll start dealing with the family members. Just to acknowledge what is meant by severe and persistent mental illness, it is the mental illness where the symptoms will be challenging and it will not respond to treatment. For example, patients who with schizophrenia that are resistant to clozapine. And of course, dementia. An important thing is that the palliative care does not require the patient to be terminally ill. That's why we have to start once a patient is diagnosed to have this kind of problems. Especially that the patient symptoms are still mild and he has some sort of insight to his problem, and he will be able to take and make his own decision with regarding the future. Who is involved in the palliative care? Actually, studies mention that family families are providing more than 75% up to 90% of the palliative care at home, or even in the hospice care centers. Usually palliative care, it is a multidisciplinary team involving nurses, social workers, doctors, physicians, psychiatrists, social service, occupational therapists, and the physiotherapy. And it has to acknowledge the patient's needs, and it depends on the needs. Where we can provide palliative care, the first step, it is at home. Usually it is preferred to provide, if it can be doable, to be provided at home, especially to keep the patient at home, less challenging environment, he will be with a loved one, and studies mention that patients who received palliative care at home, it will improve the care with the family, and also it will minimize the instance of grief later on. Another setting, it is hospice, where it will be, if there is a patient is a little bit challenging and cannot be managed at home, so he can be shifted to a hospice care, where it is a prepared setting for such kind of patients that at times managed by nurses and can be supervised by physicians. The respite care admission, where we can consider admitting the patient due to social reasons or caregivers suffer, so we'll keep the patient for the inpatient for a couple of weeks, and then he can be returned back to home. Unfortunately, if the patient is still challenging and they get, unfortunately, complications of the illness like chest infection, like pit sores, whatever, at that time we can consider inpatient admission, especially if you will be having this kind of terminal problems like severe pneumonia or respiratory distress. For the barriers of palliative care, actually, I do remember that in our hospital, we kept more than a year and a half looking for a center to accept one of our advanced young onset dementia patients. Because it is really difficult to find a place. Although there is a growing places and a growing service, I wish it would be more in the future. So availability of the resources, it is one of the major challenges. Second to that, it is the understanding of the families and to how to accept that it is just only a palliative care. Usually family will be in a denial stage. They will just looking to have their loved one back to his normal, which is unfortunately difficult. Another point of the barrier that the patient will, or could happen with palliative care, it is the lack of knowledge and the lack of training. One of the studies that has conducted in Australia, it mentioned that around more than a third of the participants, they don't have any training about palliative care. Also, one of the bigger challenges, it is this anxiety for the care providers. It is very common, unfortunately. And I do believe maybe some of us face this situation in his work. So the physician will reject the case because he will be dying in his place. And that will be counted as the morbidity and the mortality. And it can consider be something bad. However, we need to work on this and to understand it is a part of palliative care. And actually, if we will be born, there is an end point to that, which is this. Hospice care, as I mentioned earlier, it is just to provide the care for those difficult patients when there is certain criteria. I mean, within the patient life, expected life will be less than 6 months. And this is just only a comparison between the hospice and palliative care. So I will go to dementia. As we know that our goal in dementia palliative care should start from the onset of a diagnosis, even if it is mild cognitive impairment. So we need to start follow-up with the patient, setting a plan, what we call the advanced care plan. So our goal, it is prolong their life, make them as functional as much as we can, and also to provide comfort with complete safety brackets and dignity. So that's why we'll take us to what is the advanced dementia. Advanced dementia or late stage dementia, you should cover 3 criterion. Which one of them? It is to be chronic, progressive. So this means that we are dealing with a neurodegenerative, for example, like Alzheimer's dementia, vascular or frontotemporal. Also, there is profound cognitive impairment. Because sometimes, especially with alcohol-induced cognitive impairment, it can be reversible if it will be managed well. So it will be exempted from this kind of palliative care unless it is complicated. Second, the patient will have severe functional impairment. Usually, the patient with end-stage dementia, they can share the main symptoms, but only the frontotemporal, which has this kind of severe progressive course, and usually they die early. Here we can see the presentation of these symptoms and how it will start from mild symptoms, and then it will progress to that the patient will, while it's started by impairment, just impairment in the memory, it will end to be resting in the bed, even need to be supported for feeding, cannot speak at all, is mute, and also he can get like intercurrent infection, for example, pneumonia, pit sores, UTIs. We have 11 domains for dementia palliative care that also is checking it will be applicable or no. So it will be through certain criterion that has mentioned earlier. So passing through the setting up an advanced care plan. So what is the advanced care plan? Advanced care plan is a full treatment plan where we start at the onset of fixing or picking a diagnosis, and we'll start with discussing with the patient and the family, because both of them will be involved in the plan, and with their physicians to put a plan where it will respect their wish with regards to the treatment, with the future, with the financial treatment, if they are inheritance, anything like that, social consideration, spiritual things that has to be considered. Here is advanced care plan, and actually it depends upon the stage. For example, initially we will try to work on prolongation of the life and keeping the patient as much as functional as much as we can. Then it will, our second stage, if the patient is mild, we will try to keep maintaining the current function, passing to the severe stage where the patient will start to get problems like pain, like difficulty in swallowing, like problems with sleep, with behaviors. So we'll keep him as much as comfortable with complete safety and dignity, which is very important for such kind of people. Again, bereavement management, it is after this for the family or carers. So hospice care in dementia, there is certain criterion to be involved to transfer a patient for hospice care. For example, that the patient will be presented with end-stage dementia, as we mentioned. Also has certain criteria like, for example, a recurrent visit to the emergency department or the facilities. Also to be the functional assessment staging score, which is a score to be assessed for the functional assessment of the patient and the severity of the symptoms. If the mental state will not be applicable due to the severity of illness, we know that stage 1 and 2 it is for normal younger and normal age elderly. Then from 3 it is the beginning of the mild dementia, and we'll go to the end stage or the severe stage, which is the score 7. Again, when the patient should have at least one of the mentioned diagnoses, like chest infection, like ulcers, like affection, body weight loss, and impaired appetite, impaired sleep within the 12 months. I'll just go to the last part of my presentation, which is about some challenges for the symptoms in palliative care. From our experience, we could face some patients who have a lot of challenges. I will just try to cover some of them, not all. For example, the dietitian, or the eating, feeding habits, nutrition, hydration. Almost in the advanced dementia, more than 85% of patients will suffer from feeding problem. And to set a diagnosis, we need to assess the problem, and that's why we have the level of needs. So you should start from the level 1, where the patient is independent, to the level 5, where the patient is totally dependent and he needs support and feeding, and also is very resistive to the care support and give. So to manage that, usually we'll start with the non-pharmacological, which is a rule of the thumb in any challenging problem for elderly with dementia, you should start with the non-pharmacological things, like, for example, assessing the feeding needs, to socialize the eating, to also or provide some oral nutrition. Sometimes if patients might be transferred, especially in the surgical department or medical departments, for the pitch tube feeding, which is the percutaneous gastrostomy tube feeding. And it was mentioned in a lot of studies, and even in the American Nutrition Society, there is no benefit of PG tube insertion. However, it might, and even evidence showed it doesn't prevent or minimize the risk of pneumonia. The pharmacological treatment, it might be considered, especially if those patients has kind of comorbid depression, for example, and also we can provide like ametazepine, which improves appetite, improves the mood. There is some studies that is considering a possible future use of the cannabinoids like dronabinol. And even there's some evidence about how it can calm the patient down and minimize the aggressive behavior. Another challenging problem in patients with the dementia, it is the pain. Pain, it accounts more than 65%, and it is one of the major causes of a challenging behavior in those patients. And usually, it is very difficult to assess and to treat that problem. Especially our patients will be in the terminal stage, are not able to express about their needs. They were not able to complain that I have pain here or there. But we can detect that from the change of the behavior, the change in the pattern of sleep, and even through the facial expression or the emotional expression. So to manage it, we need to exclude the presence of physical problems like osteoarthritis, myopathic pain. We can consider adjusting the environment, physiotherapy, and the pharmacological treatment, which is painkiller. It is really a challenging area. Do I need to prescribe a medication or no? Usually we'll start with the least or the least constrictive measures like paracetamol or Panadol, and we do recommend pure paracetamol. It is not that mixed with caffeine because it will make them more worse. I mean, with regards to their behavior and their sleep pattern. The use of opioids. In one of the biggest studies in Australia, it is reported that around 25 to 35% of the participants who were physicians, they are not prescribing or rejected to prescribe opioids as a part of palliative care. Although, in another study, more than 80% of used morphines or opioids, it is not for the medical use. So for the last thing, it is about sleep. Sleep disturbance is very common in those patients. It may be in different presentation, like insomnia or sleep movement disorders. And usually we need to check about and exclude medical problems like infection, like pain, which is very common. Sometimes the problem with this, breathing, like obstructive apnea. Usually we're going to start with the non-pharmacological the measures like sleep hygiene, providing some massage, lavender oil, for example, keeping a routine time for sleep, providing some milk or warm drinks, darkening the room, minimize the noise. With regards to the pharmacological medication, usually even in daily practice, patients with dementia with insomnia usually they can prescribe antihistaminic, which we don't recommend because it might worsen the confusion. It might cause more confusion. Also, the tricyclic use, the antipsychotic, because of the high probability that antipsychotics could cause more side effects, and also it will double the rate of mortality in those patients. One of the medications that can be used, like melatonin, that drugs has been shown to be superior to benzodiazepine medication. And like we can start with zolpidem or zalipron. Trazodone, which is a tetracyclic antidepressant, is also one of the beneficial medication, but in low dose. The use of benzodiazepine, it is really challenging. It can prone the patients of more risk of fracture, more confusion, and sometimes a paradoxical agitation. As I mentioned earlier, mirtazapine in low dose, it could both help with sleep and appetite. Just in the summary, palliative care for dementia, it is one of the growing area in psychiatry, and our goal it is improve the quality of the patient's life, and to with complete safety and dignity. Also to consider the family support, hospice care, which is for life limiting diseases, and the area that we have covered about the nutrition and hydration. I just would like to close my or to end my presentation with this talk from Rosalind Carter. As I mentioned earlier when I started my presentation, that at moment of time we were providing care to someone. I believe maybe in the future we might need to receive a care from someone. So she said that there is four kinds of people: those who have been caregivers, those who are currently are caregivers, and those who will be caregivers, and those who will need caregivers. Thank you for kind listening, and I hope it was beneficial and fruitful. Thank you.
Thank you for your kind presentation. Are there any questions that anybody would like to ask to Dr. Walid Abdul Galil Nasser? No, if you don't have any questions, I would like to thank your audience. And I would like to make a comment. I think your presentation was excellent, particularly referring to the families who are, primary caregivers, who are not often recognized and identified as such, and highlighting that the importance of family is extremely important. Thank you. Thank you.
Yeah, I just wanted to make a comment.
Yeah, sure.
I work in WPA, so I have the pleasure and honor of working with for the last 4 years. So the aim of palliative psychiatry or palliative what dementia is, So living in dignity, so having a good life, is aimed for providing treatment all through with the medical field. In palliative psychiatry, we aim to provide good death. Maybe that evades the mind. People think that what's the aim of what we do? Having good death, having a dignified, comfortable experience. If it's inevitable, so we can't stop it. Let it be good experience for patients and their caregivers. And I can't tell you how much thanks we get from families after even the day their loved ones pass away.
No problem. Thank you. No problem. Excellent presentation, Dr. Walid. I think it really highlights an important topic that goes undiscovered when it comes to post-discharge treatments as well. When I'm thinking of palliative care at the moment, just generally in the UAE, for all specialities, we need more palliative care facilities as well. In the future, do you think there might be a need for a specialized sort of dementia-related palliative care facility, or could they be part of regular facilities for palliative care, and how that model works in other countries as well, if there are any examples?
As I mentioned earlier in the presentation, the palliative care, we do prefer to start it in homes of the patient, and there is a kind of a program in the UK, for example, that are providing the care to the patient at home, and even there is a nurse that can go to the patient, assist them, review them, and they provide some care part of the time. Unless it needs to be indicated, for example, if the patient is challenging to the family or the caregiver, at the time we can consider to like a hospice care, and if is in need for proper medical management, especially if there is severe chest infections, there is respiratory distress, or ulcer, he might need to be admitted to, for example, inpatient services. And especially at the end of the life, where it would be difficult for the family to see the loved one while he's dying. So this kind of the facilities at some time we might need, but we do prefer to provide some majority of the palliative care at homes along with the patient's lovers and the patient's family. Yeah, thank you.
Thank you, Faisal. It was a nice speech. Thank you very much.
Thanks.